clinical practice. And we have with us the panelists for the first talk, Dr. Himanshu Verma, sir, who is professor and head of Department of Nephrology and Kidney Transplantation at VMMC and Safdarjung Hospital, New Delhi. Dr. Amit Pasari, sir, who is senior consultant nephrology and transplantation at Saraswati Kidney Care Center, Nagpur, and Jawaharlal Nehru Medical College, Wardha. Dr. Varun Kumar Bandi, who is professor and head Department of Nephrology at Dr. PSIMS RF Medical College, Andhra Pradesh. For the second talk, we will have Dr. Vivek Pathak, sir, who is senior consultant nephrology and head of the department at KMCH Coimbatore. Lieutenant General P.P. Verma, sir, who is also my teacher, Principal Director Nephrology and Renal Transplantation at Venkateshwara Hospital, Dwarka. Dr. Maitri Shankar, ma'am, who is Associate Professor at INU, Bangalore. And Dr. Jitu Kurian, sir, who is Associate Professor at Pushpagiri Medical College, Thiruvalla, Kerala. So over to you, ma'am, Kinriwala, ma'am.
Thank you so much, Dr. Saurabh, for kind introduction. Should I start sharing my slides?
Yes, please.
Is it visible?
Yeah, it's visible.
Great.
You can just expand it from the bottom. Yeah. Thank you.
Okay. Is it okay now?
Yes. It's
okay. So thank you so much, Ayasot and Manish Bhai, for considering me for the talk, steroid withdrawal and minimization protocols in kidney transplant, which is close to my heart, and that is what we want to implement at our center without if there are no contraindications. So just to begin with, the learning objectives will be why we want to remove steroids from our long known helper, that is steroids. What are the risks with steroids, and what if we omit them, what benefits we get? What all various definitions steroid withdrawal or minimization has an overlapping definitions that we will look into. What all protocols are used in the world, when to be used, whether it should be used for low risk, what about high risk patients, whether we should withdraw steroids early or late, what is the evidence that suggests short or long term outcome, and what about India. Our Indian experience will be mostly shared by the next speaker, Dr. Vivek Pathak. So I will not be talking about in general, but we will share our experience, how we are doing at our center. So this is a very well-known graph. Since 1960, the steroid has been introduced and helped us for various organ transplant in humans. And later on, then we have various drugs that has helped and improved our 1-year graft survival with introduction of CNIs that has improved better, and 1-year acute rejection episodes has dramatically reduced. However, over period of time, though a transplant has evolved, we still face various side effects of drugs, or if we don't give, then rejections. That is still a dilemma. If we broadly classify immunosuppression agents, there are mainly induction and maintenance immunosuppressions. There are few which can be used both in induction and maintenance. The very well known are the basiliximab, that is IL-2 inhibitors. The cousins of basiliximab are not available at present. The another is ATG, that is antithymocyte globulin, Rabbit ATG. The alemtuzumab or Campath is not yet available in India. However, in Western world, it has been widely used, specifically when we are planning to have steroid withdrawal or in highly sensitized patients. There are few studies where they have used Ritux in various combinations in non-ABO incompatible or ABO compatible transplants. Dr. Vivek Pathak will be sharing his experience on it. There are few like belatacept and glucocorticoids, which are used both in induction and maintenance immunosuppression. And all we know is that the triple immunosuppression, where we use either of these, tacrolimus or cyclosporin, along with mycophenolate and steroids. In few patients, we do use azathioprine or one of the mTOR whenever indicated. So why we want to reduce steroids or withdraw steroids? So apart from various toxicity that steroids exhibits from head to toe, the most worried steroid toxicity in transplant, where they are supposed to take steroids for lifelong, the most deadly worrisome complication or toxicity is risk of infections, be it viral, fungal, or bacterial. In adult patients, we are again worried about cardiovascular morbidity and leading to mortality. The lesser significant side effects, but long-term implications are hyperlipidemia and hypertension, post-transplant diabetes mellitus emergence, or worsening of the glycemic control if a patient is already diabetic. Then there are also issues raised for bone health. In children, particularly, steroid has detrimental effect on growth. That is why we want to withdraw or minimize our steroid to prevent its various toxicity. Recently, a very large cohort that has been published in 2025, where they have assessed the cardiovascular outcome in kidney transplant recipients, steroid-free versus steroid, where they have included more than 8,000 patients over a period of almost 11 years. And what they concluded that the early consideration should be given to minimization of steroids in kidney transplant recipients with dyslipidemia or diabetes to optimize their cardiovascular outcomes. So steroid has significant effect on cardiovascular morbidity as well as mortality, especially those who already have dyslipidemia or diabetes to begin with. If we talk about bone mineral density, then again, there is a published literature in 2025 recently, where they have looked at retrospectively in 132 patients, where they have proved that the steroid withdrawal after kidney transplant positively impacts bone mineral density with higher cumulative, as and when we increase the dose of steroids, they are associated with poor bone health. So what we are looking at, what benefits we get if we reduce steroids or withdraw steroids? So it will reduce metabolic complications like obesity, diabetes, hypertension. It will improve growth, especially in pediatric patients. It will reduce cardiovascular risk. It will improve quality of life. And sometimes it may be cost effective if we look at the cost required to treat or prevent complications of steroids. However, there is also a risk. There is a risk that we are always worried about risk of acute rejection. There are a lot of paper that suggest that the subclinical inflammation that goes behind without steroids may be the risk factor for higher incidence of chronic allograft injury. This also need a close monitoring and early intervention, which may add to some cost if we follow steroid withdrawal or minimization protocol. So what do we aim for? So steroid minimization or avoidance strategies should be used to aim to reduce long-term corticosteroid side effects in carefully selected patients. The patient should be carefully selected with vigilant monitoring. In patients where we can monitor them, then only we should try or opt for steroid minimization or avoidance. So what are the various types of steroid minimization protocols? The definitions do overlap in various studies. However, this is the commonest that has been followed, that complete avoidance when you are not using steroids and you are using extended induction. The most common induction agent that has been used is alemtuzumab or very high doses of ATG up to 8 mg per kg. You withdraw steroids within a week, that is within 7 days. The induction agents that has been used are alemtuzumab, ATG, sometimes basiliximab too. When you withdraw steroids between 7 days to 1 year, you do give induction and withdraw steroid over a period of time like 3 to 6 months. And when you withdraw steroids after a year, which is called as late withdrawal. People may have used induction or not used induction in this group of patients. So if we look at the regimen without steroid, where complete steroid avoidance has been used, the adverse outcome that has been observed are the chronic allograft nephropathy has increased by 2 times. However, evidence is still, we are still waiting for the long-term outcomes. If we use low dose steroid maintenance, that is what we do conventionally, there we have the rate of CN decreased by half. However, the steroid side effects are seen very well. If we withdraw steroid early post transplant, then the chances of decreased long term survival are there. If late withdrawal, then there are 34% excess risk of graft failure and 14% chance of acute rejection. We'll go into detail of adverse outcomes or a benefit outcome in with specific studies, and we'll look into in detail. So the most important thing that we believe is whenever we are talking about steroid withdrawal or minimization protocol, the patient selection should be very careful, and that should be followed on individual basis. So this has been proposed criteria for late versus early steroid withdrawal. Those who are having high risk of rejection, like African American or pediatric patients, or highly sensitized patients, or a patient has second transplant, or when the child has or a patient has low risk for steroid side effects, there we can consider for late withdrawal. Early withdrawal should be aimed whenever we have low risk of rejections, like first transplant, living related, or well matched, at least haplomatched transplant, or patients who have high risk for steroid side effects like diabetes mellitus, existing osteopenia, postmenopausal female, or if there is family history of diabetes mellitus. However, this has been given way back in 2002. After that lot of evidence has come up, and we do have a favorable outcome, long as well as short-term outcome in early steroid withdrawal protocols. The next comes which induction agent to be used. There are no head-to-head comparison between the various induction agents. However, broadly, 3 induction agents have been used in various studies. This is RATG in various doses from 1.5 to 8 mg per kg with different protocol and monitoring. Alemtuzumab has been widely used in steroid avoidance or early steroid withdrawal. The European countries where IL-2 blockers are used as the primary induction agent in steroid withdrawal or steroid avoidance protocols. So as you can see, the induction agent has been used in combinations or alone in various doses with various days of steroids. The most of them have stopped within 7 days in early steroid withdrawal. Maintenance immunosuppression mainly based on one of the CNI and mycophenolate. However, people have also used CNI minimization or no CNI protocol, where they have used sirolimus, low dose sirolimus, along with low dose tacrolimus. And as you can see, the biopsy proven acute rejections are not that high, as well as the graft survival or outcome in various single as well as multi-center studies are not that bad. So this is Dr. Suresh Kumar has recently analyzed OPTN data for influence of induction agent on disease donor kidney transplant recipients on outcome when they have steroid-free maintenance immunosuppression. And what they have, where they have analyzed almost 5,000 plus 5,000 in RATG and 2,000 plus in alemtuzumab group of patients. And what they have concluded is that when compared with alemtuzumab and IL-2 receptor blockers, RATG induction seems to be associated with superior outcomes in diseased donor kidney transplant recipients maintained on calcineurin inhibitor or mycophenolate. So be it a rejection, be it biopsy proven rejection, or be it a graft outcome, in both the ways, RATG is better than basiliximab as well as alemtuzumab. The similar comparison was also done for alemtuzumab versus ATG as induction in non-sensitized, that is what we target, primary non-sensitized live renal transplant where early steroid withdrawal was planned. What they have concluded is when alemtuzumab and ATG is compared, there is low risk of severe rejection in ATG group as compared to alemtuzumab, and BK nephropathy is also more in alemtuzumab, which is very contradictory, and we need to have more evidence to compare alemtuzumab versus ATG. However, these two studies have given a background that amongst three, our ATG seems to be better option at present. So what about the long-term outcome? So recent publication by Saylor Group, there they have compared steroid avoidance where they have used ATG as an induction with low dose TAC and MMF as maintenance immunosuppression, and steroid maintenance where basiliximab has been used as an induction agent, and along with triple immunosuppression, low dose TAC, MMF, and prednisolone. And there it was compared, the patients were randomized, and what the findings were that the death sensor graph survival was almost similar. Patient survival was almost similar and statistically not significant. Biopsy proven rejection, though, was seen a little more in steroid avoidance, but statistically not significant. And kidney function at 7 years, that is the longest documented outcome in steroid avoidance with head-to-head RCT trial, had shown no statistically significant, concluding that steroid avoidance is safe and effective in patients with low immunological risk, at least up to 7 year post-transplant. Then what about high-risk transplants? The high-risk definition is different for everyone, but what should be followed are the patients who are sensitized, patients who are second transplant, and few of them have also taken children as high-risk transplants. There are not more studies or appropriate studies where a systemic review or meta-analysis can be done. However, in 2018, the Chinese group had tried to analyze where they have used more of a case series, cohorts, retrospective cohorts where different definitions for high-risk patients were included, and they concluded that the steroid withdrawal or avoidance following high-risk kidney transplant is safe in terms of graft survival and rejection, and patient undergoing this regimen had a lower risk of death and post-transplant diabetes mellitus. However, the conclusion is the authors were not concluding it as firm because they do not have the good power of these various studies. Almost after 5 to 6 years of last meta-analysis and systematic review, in NDT recently published, where they have compared head-to-head first transplant recipients and retransplant recipients in adults, where their focus was to examine whether the impact of early steroid withdrawal on kidney transplant outcome differ between first and retransplant recipients. So what they found is the rejection rates were 4% in first transplant recipients when they have used various different protocols. The protocols were different, so that cannot be concluded. But amongst the almost 2 lakh patients, the rejection rates were only 4%. However, rejection in retransplant recipients were very high, 26,000. Amongst 26,000 patients, 42% rejection rate. Even the graft failure was, the incidence of graft failure was also high. And the death, though it shows that the first transplant recipient has more, but it was statistically not significant. So they concluded that retransplant status may adversely alter the risk-benefit balance of the steroid withdrawal in this kind of patients. Then the question comes, what about biopsy proven acute rejection? What should we do? Whether we should put them on long-term prednisolone or what to be done? So there are no good published literature. However, there are two schools of thoughts. Those European countries have followed that if they have biopsy proven acute rejection, they do start them on low dose steroid, mainly to prevent second acute rejection, which may be deadly, or which may be the person can lose the graft also. There is also another school of thought where people have tried to shift them again to steroid free or avoidance protocol after treatment of acute rejection. However, there are chances that these patients can have second biopsy proven acute rejection, and the graft survival or long term graft survival may not be as good as the low dose maintenance steroids after biopsy proven acute rejection. However, there is no conclusion yet. So what do we do at our institute? We follow a protocol that has been given by Hemil, and we have modified a little bit of Hemil protocol. So the patients who have been concluded to be enrolled for early steroid withdrawal, they will receive RATG as an induction. They will be started on low dose TAC as well as MMF from day -7 to day -2 based on their counts. And on day 0, they will receive 1 to 1.5 mg per kg of ATG. Day 1, again 1 to 1.5 mg per kg ATG. And after 3 mg per kg, we'll monitor CD3 count. If CD3 count, absolute CD3 count is less than 50, then child will not receive another ATG dose. If it is more than 50, one more 1 to 1.5 mg per kg of ATG will be given. So maximum 4.5 mg per kg ATG is planned, not more than that. For steroids, day 0, child will receive 7 mg per kg. Day 1, child will receive 2 mg per kg of IV methylprednisolone. Day 2 and 3, again, sorry, there is a typing mistake. Child will receive 1 mg per kg on day 2 and 3 of IV methylprednisolone from day 4 onwards to day 7 till we achieve target trough level, that is almost 10 to 12, more towards 12. Child will be on 0.5 mg per kg, and no child will be on steroids after post-op day 7. So what monitoring we do after steroid withdrawal when once child is enrolled in steroid withdrawal protocol? Of course, we target tacrolimus trough levels, and we do a little frequent monitoring. With initial first month, we target at least 10 of tacrolimus trough levels. We also do viral surveillance for these kids for month 1, 3, 6, and 12 post-transplant. The viruses that we do surveillance are BKV, CMV, and EBV. We have recently started doing TTV surveillance just to monitor them for the replications and their overall immunosuppression status. We also do single antigen bead assay at 1, 3, 6, and 12-month post-transplant. And if it is suggestive of emergence of DSA, then child will be opted for biopsy. Otherwise, protocol biopsy will be done at 6 and 12 months. And of course, for cause, SABA or protocol biopsy will be carried out. So my take home message will be immunology is an art. We all know it is not a science. For steroid withdrawal protocol, careful selection of patients with judicious monitoring post-transplant is the key. We should focus on steroid minimization protocols which will improve growth, metabolic profile, and quality of life. However, it should be avoided in high-risk patients without we have a strong justification, and our goal should be personalized medicine. Thank you.
Thank you, ma'am, for that excellent overview and for breaking down the complex clinical decisions into clear, actionable protocols. Your practical insights will certainly help our audience in tailoring the steroid use to patient-specific needs. Now, coming to the panel discussion, the first question is for Amit Pasari, sir. So, sir, in which subgroup of transplant recipients do you consider early steroid withdrawal be safe and sustainable?
As madam also pointed out, patients, mainly the patients, those patients are selected for steroid withdrawal who have significant side effects or who are perceived to have significant adverse effects related to steroids, like pediatric patients or patients who have already received long-term steroids for, say, glomerulonephritis or SLE or autoimmune disorders, or who have osteopenia as pre-existing condition. And for transplant-related factors for these patients, we should we will generally prefer for patients who are low immunological risk, who have negative cross match, not significantly elevated PRS, and patients who are preferably undergoing a live-related kidney transplantation and who are receiving induction therapy. These patients are considered for early steroid withdrawal. And patients who have immediate good graft function after transplantation, all these patients we will be considering for early steroid withdrawal.
Thank you very much, sir, for clearly identifying the patient profiles where this approach can succeed. Next question for Dr. Himanshu Verma, sir. Sir, what are your preferred induction corticosteroid regimens in standard risk versus high risk transplant recipients?
Good evening, everybody. Thanks, Saurabh, for the question. Actually, as we deal in the adult transplants, so we generally divide the patients into low immunological risk, medium, and high immunological risk. In the low immunological risk, mainly the siblings or mother to son, mother to daughter, these transplant good HLA match. So these patients, they are good results if we use the steroid induction. Means we can use methylprednisolone pulses pre-operatively, and I think on the second day we can start with prednisolone of 0.5 milligram per kg, and then we can taper it to the lowest possible dose in around 4 to 6 weeks, approximately 5 milligram. But in the patient with the medium immunological is mainly those are the spousal transplants or husband to wife, in which wife is only sensitized. So in these transplants, we prefer the induction with the basiliximab along with the steroid, and the same protocol of tapering down the doses in 6 to 8 weeks to the minimum steroids. And but in high immunological risk patients, it is better, such as the second transplant or third transplants, multiple pregnancies, multiple blood transfusions, or cadaveric transplants. So these are the high PRA. These are the high immunological risk transplants, and in these transplants, the risk of rejections are quite higher on the higher side, and therefore the rapid ATG can be used along with the steroid protocols, and the steroid minimization can be done at a relatively longer duration, approximately of 2 months or so, so that we can minimize the risk of rejection and can have better 1 year graft survivals. But as we were I was just going through the talk of madam regarding the steroid withdrawal and the steroid avoidance. So here it is in the pediatric population, if you will consider, because these are the patients who even after transplant they have to grow. So there's a bone growth, osteopenia, and all these things. So in these patients, mainly there are a lot of studies which points towards the steroid avoidance or steroid withdrawal. As ma'am said that within in the steroid withdrawal, in 1 week we have to withdraw the steroid and keep the patient on ATG and tacrolimus and MMF. But the important issue here is that you should have a very close monitoring. You should have a protocol for protocol biopsies, and these patients are those patients who are in first transplant, low PRAs, and good HLA matches. So they are very means very unique and specific population where you can go with these, because I have came across a transplant when I was in the early stages of my practice, in which a pediatric patient, she was subjected to the steroid withdrawal, early steroid withdrawal within a week, and mother as a donor. So, but that patient landed up into acute rejection. But that was a single case. We cannot have a extrapolate it to the whole population. But that girl landed into the acute rejection, and then we have to treat the rejection. But she had good response, and then we have to keep her on the steroids. But even after 10 years of graft function, she is having good graft function, and the growth is also optimum. So I would like to go with the minimum steroids for the means to continue the steroids for the long duration in the minimum dosing. And I think renal transplant we can't go without steroid. Maybe the newer induction agent like alemtuzumab, when we will be using it, that may open up a pathway for the steroid withdrawal or steroid avoidance protocols.
Thank you very much, sir, for reiterating the need for individualization and differentiating between the standard and high risk groups, and for sharing the strategies that can easily be applied in our day-to-day practice. Thank you, sir. Next question is for Dr. Varun Kumar Bandi, sir. So, what monitoring parameters or red flags guide your decision to reintroduce corticosteroids after attempted withdrawal?
Okay. Good evening, and thank you, ISOT, and thank you, Saib, sir, for the opportunity. So, first of all, good talk by ma'am. So, regarding the monitoring wise, it is first thing, it is the disease wise and also the toxicity wise. So, if we are looking for creatine monitoring, any evidence of worsening creatinine or any doubt of rejection, we go ahead with the steroid. Second thing is if protocol biopsies are banned, if protocol biopsy shows even borderline ejection, even if band 1A or borderline ejection, then there is some evidence that you better start them on low dose of steroids. Second thing, same thing with DSS. So, if we are monitoring a donor specific antibody and you see a rising titers of DSS, then again better to put them on steroids. Two other things will be if your patient is developing TAC toxicity. TAC itself, TAC and MMF, we tend to use higher doses in steroid avoidance. If those are causing side effects, then again we have to come back to steroid and cut down the TAC dose. The another point of the same thing is increased CME and BKV. Against steroid evidence, they tend to have higher chance of CME and BKV, could be because of high dose of TAC. So these scenarios, we cut down TAC MMF, we decrease the TAC MMF, and we can start them back on low dose steroid. And one out of this is if the patient starts developing proteinuria or recurrence of the native disease. That is one more indication where we have to look for and restart them on steroids.
Excellent points, Bandi sir. Your practical red flags and biomarker-based approach give your audience a strong framework for decision making. Our next talk is on recent advances in steroid-free protocols. And as we all know, this is a rapidly evolving area where trial evidence is challenging the traditional norms, and newer biomarkers may soon redefine the patient selection. So, speaker is Dr. Vivek Patak sir, who is senior consultant and head of department at KMCH Coimbatore. Over to you, sir.
Good evening, all of you.
Good
I
evening.
think I was the first one in the country, or one of the few people who started tacrolimus way back in 2002 and 3. I started offering tacrolimus to my patients, and I said, this is a better drug than cyclosporin. If you accept, I'll use this, and I was sending the levels to Mayo Clinic and Singapore General Hospital. When I realized this, when I added tacrolimus and immunosuppression, almost every other patient who was non-diabetic became diabetic. I thought there is no use giving steroids to these patients. So I started withdrawing steroids for these patients. And that's how this study has come from. Initially, 15 or 20 patients, I saw what is happening. And I thought results were good. And post-transplant diabetes virtually disappeared. So the story over 20 years of more than 2,000 patients, 7,000 biopsies. I have got the entire data of incidence and prevalence of recurrent bronchitis in the post-transplant group because I had done the protocol biopsies as well. So this started, steroid-free transplant started in 2004, but I have not included data of 2004 because at the time I was using OKT3 for induction, not thymoglobulin. So I'm including this from July 2005 onwards, and the entire cohort of this 20 years is based on thymo induction. Prednisolone is the least expensive drug, but associated with most side effects, and we have seen all patients in the previous era with monster faces, hip fractures, and cataracts. Causes of ESRD in this group the same. This trial is from July 2005. It's no longer a trial, but it's for study purposes. I took the statistics in June this year. This control group is the tacrolimus group, in which I added 5 mg of prednisone at the end of 1 month before I started thymoglobin induction. This is 2,100 patients, and obviously in any country, most of the patients are males. I have a habit of looking at the cardiovascular profile of all patients. So I do the pre-transplant nuclear scan, myocardial profile scan for all patients who are diabetics and elderly hypertensives. So this includes about 19.5% patient underwent the procedure, and we did 57 bypasses, that means 2.6%, and angioplasty was done for 1.6. So 4.2% patients underwent revascularization before transplant, because I don't like to lose a patient's post-operatively because of acute coronary syndrome. This is the data about the prevalence of TB and hepatitis B and C before transplantation, and nearly 92 patients belong to an age more than 60 years of age. Thymo induction, I used 3 doses. The dose is from 3.8 to 8.5. Mean dose around 4.2 to 4.3. 8.5 is a revision. Actually, maximum I have given to one patient is 15 milligram, but 8.5 also is rare. Mean dose is 4.3. It depends on CD3 levels. And rituximab I'm using for last 20 years, and 200 milligram for high-risk recipients. And I avoid it for elderly diabetics, but more patients suffering from glomerular diseases. Levels are maintained between 6 and 10. Steroids are given for 4 days. First day 500 milligram and 25% I cut every day. And by day 5, prednisone is nil for all patients. I do not differentiate high risk and low risk. For all, steroid is nil by day 5. Well transfer prophylaxis I started before it was introduced in the country in 2004. And I am giving to all patients for 60 days, once a day, not 2 times a day. I was proved to be right later when we realized the dose in less than 60 ml of GFR, 1 BD is not required, which is used in the Western world. Trimethoprim sulfamethoxazole prophylaxis is required. Initially, I was giving for 1 year, but then last 10 years, I have given it to everybody lifelong. Biopsy-proven acute rejections were treated with sorbitol 255 milligram for 3 days, and additional medications for antibody-mediated rejection like plasmapheresis and IVIG were given whenever required. Observation period is 1 to 237 months. First transplant 2065, second transplant 57. I give prednisone free for second transplant as well. I don't differentiate anything. Live donors were 2,124. Mean age was 45 years. Creatinine was 1.1 at 1 year and at 1.5 milligram at 19 years, because 20th year is actually started in July 2025. Pre-transplant diabetics were 602 and post-transplant new diabetes 6.1, compared to 43% when I was adding prednisone 5 milligram and 24% at the end of 1 month. It is just nowadays at the end of 1 year, it's not even 1%. 6.1% is over a period of 2 decades. I am doing biopsies for all patients at 3 months, 1 year, 5 years, and 10 years. 10 years biopsies I stopped now because it does not add much to the program. So a rejection was seen. Biopsies are both protocol and indicated. So acute rejection, I always biopsy and give the treatment, because I can do the biopsy by evening or next day morning, you know the result, 9.2%. Subclinical rejection is always in a steroid-free group. This was 4.2%. Total rejection is 13.2%. Now look at survival figures. Look at here. First year number is 2124 and survival is 97%. By 10 years when I come, survival is, if you look at here, is 85.8%, and by 19 years, you come here, 665 patients have reached almost 10 years, and survival is still fine, nearly 90% plus. Put the previous one. Now, previous one. If you look at this slide, you realize most of the losses are in the first 5 years. Some 7 or 10 years, it's a flat curve. You don't lose many patients in this protocol beyond 7-8 years. It's almost a flat curve. You see the survivals are good, because prednisone is not there and cumulative dose of prednisone is less. Look at the graft survival, look at 1 year, and then look at this one at 19 years, it's around 92%. This is the death censored graft survival. Before that was the graft survival. If you look at the figures of this again at 10 years, it's considerably high, 84% at 19 years. Death center is again very high. It's starting from 99.5 to 92.8. How many patients remain prednisolone free year by year? When I try prednisolone for everybody, it does not mean the 100% patients are prednisolone free. At the end of 1 year, around 86 or 87% are prednisolone free. At the end of 20 years, still 20% patients are only on prednisolone, which is in the range of 2.5, 3.55 milligram. Which are those patients who get prednisolone? First, who are taking already from the first transplant 5 milligram. I reduced to 2.5. I'm not able to stop it because they're already on that for a few years. Some patients have glomerular diseases like lupus nephritis who are coming to me with already a dose of 5 milligram for last many years. Then if biopsies show a lot of IFTA to prevent further fibrosis, I end the prednisolone. Acute rejections, initially I was making them steroid free, but lately I've added, though I had nothing to regret about not adding prednisolone in the initial few years. But some other reason I give it, but I don't think if you don't give also, nothing matters. So steroid free continuing at 237 months, that means nearly 20 years is 80%. How many grafts I have lost in that period? 89. How many patient deaths? 134. These are the reasons for the graft loss. Antibody-mediated rejections, chronic allograft nephropathy, recurrent IgA nephropathy, recurrent focal sclerosis. I have got the exact numbers because exact number is all entered every month in all my data. Non-compliance with 13, tuberculosis of kidney 1, CNI toxicity 2. Causes of death, hepatitis related in the previous era. We have hepatitis C treatment only for last 10 years. Before that, it was not there. So hepatitis related infections, which include maybe any kind of infection, septicemia patient died. I am not classifying it pneumonia or UTI or anything else. COVID infections, we had 21 deaths. Cardiovascular diseases 17, cerebrovascular 13, non-compliance with drugs 32, malignancy 9. I got the exact data malignancy as well. Other complications in this protocol, what I have seen, tacrolimus-induced red cell aplasia 5. These are the patients with a very low hemoglobin in whom pyrovirus test is negative and bone marrow biopsy shows PRCA. You switch them from tacrolimus to cyclosporin, and next 4 months they'll recover. Peripheral neuropathy in 4 patients, including Guillain-Barré-like patient in 1 patient. CNS toxicity 1, tacrolimus-induced diarrhea. This patient had diarrhea for a few months. We stopped MMF, but he did not recover. Colonoscopy was normal. We converted him from tacrolimus to cyclosporin. He recovered. One other patient was having considerable bone pains for months together. Ultimately, we stopped his tacrolimus and he recovered. Infections. We had tuberculosis in 87 patients, that is around 4%. Cryptococcal meningitis in 4, nocardiosis, aspergillosis, mucormycosis in 14, and out of 14, 10 recovered. Leukopenia is more common in these patients. The definition of leukopenia is not like steroid plus transplants, where less than 4,000 you take as a low WBC count. Here I take anything less than 2,000 as low WBC count. 2,500, 3,000 is normal. CME infections in 1.6% because I give routine prophylaxis for 2 months. BK virus infection is prevalent in 2.8% patients, that's 61 out of 2,124. Parvovirus 13 patients. Renal artery stenosis requiring stent is unusually low because cardiovascular surgery than anastomos for almost 100% patients. How many patients developed revascularization after transplantation? In 20 years follow-up, 4 patients required bypass and angioplasty and stenting were done for 38, that is 1.7. These are the patients who developed the cardiovascular paralysis post-operatively. This is the data of malignancy, which I don't think has been reported from our country. If you look at this, the total number of malignancies is 42 in this group. That 1.9% patients, all patients develop malignancy. out of which native kidney malignancy I have seen in 15. No deaths because we do routine ultrasound periodically every year, and we picked up the native kidney malignancy on periodic ultrasound, and we subject the patient for laparoscopic bilateral nephrectomy, and no patient ever recurred or died. PTLD, we have got 17 patient, number of deaths is 2, and 2 or 3 patients are ongoing in treatment. It is not a frightening disorder. PTLD is curable in most of the patients. In fact, I have done a kidney transplant for my own patient who developed PTLD in the 7th or 8th year. We did chemotherapy for that lady, waited for 1 year, and we did a second transplant. She has again finished 7 years following second transplant. Acute leukemia 1, liver cancer, lung cancer, cholangiocarcinoma, ovarian cancer, brain cancer, glioblastoma, and cancer of unknown origin. Now I'll compare our figures to US survival figures. Look at the US data of overall dialysis and transplant figure and survivals. If you look at that, it's not very encouraging. Living donor and deceased donor, I'll show you in the next paragraph. Look at the if you look at here, at 20 years, deceased donor transplants, the patient survival is 31.9%. Living donor is 68.9%, compared to what I have is nearly 90%. And overall transplants is 36%. Graft survival is 18% in cadavers and 51% in living donor. And these are steroid plus patients. They are not steroid-free transplants. The overall survival of patient and graft. And overall survival graft is 21.8% at 20 years. And death censored graft survival is around 41%. So our data is considerably better over a group of patients who are dependent on maybe 5 mg of prednisone throughout life. Now, the second part of my talk is about recurrent glomerulitis, because I do not think I have seen any data from India on the exact incidence and prevalence of post-transplant recurrent glomerulitis. Because I do the protocol biopsies and indicate biopsies as well, I am in a position to say what is the numbers of recurrent glomerulitis post-operatively. Though we know that pre-operatively, good number of patients are suffering from chronic kidney disease because of chronic glomerulitis. And recurrent glomerulitis is an important cause of graft failure and long run. The risk of graft loss increases from 0.6% at 4 years to 8.4% at 10 years. Second part, which you should know, is the data has been published many years before, that if you do a steroid-free transplant, the graft loss is higher, especially not FSGS, but IgA, recurrence of IgA nephropathy. I'll point out today what data I have to show to all of you. This there's another gentleman who reported second time that there was no increase in recurrent IgA in rapid steroid avoidance protocol. So in this study, I have documented the incidence of glomerular disease in a rapid steroid avoidance protocol with a recurrent DIVO and other diseases. Graft failure was defined as death with a functioning graft, return to dialysis or retransplant. Recurrent or de novo disease was confirmed by histology. Recurrent FSGS was diagnosed by sudden onset of proteinuria. I can tell you, even if somebody gets 1 gram proteinuria or 10 grams proteinuria, if you do light microscopy or immunofluorescence, you will see nothing much. And if you see electron microscopy, you will not get result for 3 weeks. So if you think somebody has sudden onset of proteinuria and his patient is not coming down to stationary after a few days, that I take as a recurrent FSGS, the biopsy is normal. Now, this is the data about recurrent IgA nephropathy. I cannot compare to any other center because I haven't seen results. I had, out of all my patients, pre-transplant chronic IgA nephropathy was present in 290 patients, that is 13.7%. It was biopsy proven. Post-transplant, I have seen 89 patients, that is 4.2%. Recurrent IgA was seen in 31. Recurrent IgA means with these patients, I knew the basic renal diagnosis was biopsy-proven chronic IgA. And this biopsy-proven IgA had a recurrence in 31 patients. And then there are remaining 58 patients in which there was a post-transplant IgA. This could have been recurrent or a new, because I don't know their diagnosis. What was the diagnosis of the original kidney disease? They were not biopsy-proven patients. We lost the graph in around 12 patients. Pre-transplant is 13.7, post-transplant is 4.2, and mean time of recurrence is 48 months. In the literature, it's almost the same. Mean time of recurrence is 48 months. But what I see actually in IgA is the post-transplant IgA responds well to enhanced immunosuppression with prednisolone, use of hydroxychloroquine and AC inhibitors. And if you continue steroids at little high dose for 4 to 6 weeks, good number of patients develop remission of proteinuria and they do well. So that's why if you see 89 patients got a disease, but only 12 lost the graft. So graft loss is just because recurrence happens does not translate into graft loss. 2091 patients underwent, notice to should be 2,100. This about 100 patients are there who diffuse biopsy or I could not do for some reason. They underwent nearly 6,914 biopsies. 1 year number biopsies are 4,168. Includes protocol biopsies at 1 month, 3 months, 1 year, 5 years, and 10 years, and indicator biopsies whenever required. Normal biopsies are, or biopsy-free acute rejection was 81.5%, and acute rejection is 9.2%. At 5th year, again, biopsies were nearly 81% were normal, and remaining some biopsies show significant IFTA. At 10th year, total biopsies were 74 and 80% biopsy were complete normal, as if you are seeing the normal kidney biopsy. I stopped after 74 10th year biopsies because it was not providing any more significant information. I did all those biopsies because I did not know whether I'm doing any justice to the patients by not doing the biopsies, because steroid-free protocol was not done in our country, and I want to be very sure whatever I'm doing the patients, I'm right. So biopsies showed me at 1 year, 5 years, and 10 years, starting from 3 months onwards, I am right. So recurrent IgA is 4.2. Other findings are interstitial inflammation of unknown origin 1.8, BK virus 1.9% patients, and some are as rejections. Now, second diagnosis, which is more common in these patients or less common, 71 patients of recurrent FSGS. Out of the 71, 34 had a biopsy who were native kidney diagnosed of FSGS. 7 patients lost the graft. I started rituximab in these patients in 2007. First publication came in Transplantation around 2017 or 18, but I am using since 2007 in the belief this will work for those patients. And I found complete remission in 55 out of 61 patients, partial remission in 8. Now, FSGS is a disease of multifaceted etiology. The final picture may be FSGS, but etiologies are many. So all patients are not going to respond to rituximab. Some will not respond. So it's a preventable graft loss in majority of patients. Mean follow-up is 52 months. Recurrent dense deposit disease, I have 2 patients, electron microscopy proven. 1 patient lost the graft in 1.5 years, while other is doing well at 13 years, though he has recurrent proteinuria. In fact, last week he had angioplasty and stenting at 13th year, but his creatinine is only 1.8. Diffuse proliferative glomerulonephritis, 2 patients, resolved over next 18 months. Recurrent myeloma in 1 patient, lost the graft. That was within first month. I think I missed that preoperatively. Post-transplant, this is the total picture of glomerular disease in India. IgA, FSGS, membranous, 3 patients, 1 membranous actually recurred. 3rd day post-transplant. 3rd day post-transplant patient got proteinuria. I did a biopsy. It was a picture of membranous. PLA2R positive. Then I sent a serum PLA2R. That was also positive. And I treated him with rituximab and he's doing well. Dense deposit disease, I told you 2 patients, anti-GBM1. Now, this anti-GBM1 is not a native kidney disease anti-GBM. I'll tell you about this. C3GN2 patient, total 7.9%. Now, this anti-GBM was found in a patient with Alport syndrome for whom I did a second transplant. So, this anti-GBM is directed to epitopes in alpha 3, 4, 5 chain of the type 4 collagen. These epitopes are not present in the substrate used in the conventional anti-GBM sera. So this is the reason for negative anti-GBM test in the Alport's patients. This patient responded well to plasma exchange, and this patient was suffering from Alport rhizome second transplant. His immunofluorescence was positive for anti-GBM, but his serum sample was negative for anti-GBM. And I've explained to you the reason why serum sample was negative, and she did well with follow-up plasmapheresis. Crescentic glomerulonephritis recovered. Serum creatinine decreased. Now, this is about my data about the Kaplan-Meier survival analysis of allograft loss due to recurrence of glomerulonephritis rejection, death. If you look here, First reason for graft loss is death. We are lost 7.1 to 1% first graph. This one, you can see it here, 7.1%. The second reason is others, could be anything. Third reason for graft loss is recurrent glomerulitis. You see the third graph, it is around 0.95%. See the third graph. And rejection graft loss is 3.04%. We'll go to the next one. Now I have compared here. This is the data for Brigatti from New England Journal of Medicine, published almost 25 years before. This data is not on steroid-free protocol, but this overall data from US about the incidence and prevalence of recurrent glomerulitis in the transplant patient. If you look at here, glomerulitis loss is 8.4% over a period of decade and a half. But I am talking of just less than 1%. Death is the commonest cause. If you look here, graft loss for me, and here as well. And here, chronic rejection is responsible for 20.3% cases of graft loss. So death with a functioning graft is 15% in the series, and death with a functioning graft is 7.12 in my patients. This is the New England Brigatti graph, and this is my own graph in my patients, which biopsy proven all patients. Anybody who complains of proteinuria, nobody refused biopsy. We did biopsy for those patients, and EM was done whenever required. So now I'll tell you something about the literature survey about the recurrent glomerulitis. This was a picture of Brigatti. I was talking graft loss to recurrent glomerulitis, 8.4% at 10 years. One Wisger, higher IgA and steroid-free protocol. But the problem with most of this publication is they are basically meant for various kinds of studies. They'll have different protocols. They have been done in different eras. So many of them will not have thymoinduction. Many of them will not have tacrolimus. Many of them will have combination cyclosporin sirolimus, tacrolimus sirolimus, cyclosporin azoran. So this is difficult to compare to one group. This is not a one homogeneous group. It's a heterogeneous group. Now look at another significant publication of recurrent GA from Clayton. Overall graft survival, graft loss from recurrent GA was 4.3% here, which is exactly equal to mine of about 4.2% graft loss. No graft loss in this series for those patients who received thymoinduction, indicated better thymoglobin. I have got some patients who have lost the graft, 12 patients who are out of this entire group in spite of thymoinduction. But this is showing a protective effect. This is another publication which again says the same thing. Higher rates of recurrent glomerulitis but not translating into graft loss, thymoinduction use, recurrent GN is 19.2% at 7 years, and I'm showing less than 1% at 19 years. This is another combination by Kukla et al. Publication. If you again, this also shows what is common in all those publications: a strong protective effect of ATG induction. ATG induction 9%, glomerulonephritis, no AT injection almost 41%. Pascal, again the ATG reduces the rate of recurrent glomerular diseases compared to IL-2 induction. Now, reasons for reduced graft loss in our series. One is thymoinduction, which was not done in many studies in the last 30 years, which is more prevalent in the last 2 decades in US also. Previous time, basilicimab was more common. That I think reduced the risk, perhaps there is risk of IgA, which many publications show. Maintenance drugs varied in the same series. Multiple combinations were studied for comparison group, which I did not do. My group was fairly consistent, tacrolimus MMF throughout. Third is protocol biopsies done, so I could identify the problems much earlier. Intensive follow-up, I see my own patient for 3 months almost 30, 40 times in the 3 months, 50 times. Graft loss due to recurrent FSGS reduced by rituximab use. I'm using this, actually, if I had published that in 2007, that would have been the first publication of the world literature. I still have those files with me, which I have shown to many people who visited me from US. Many patients of recurrent IgA responded to higher dose of prednisone for a few weeks, ACE inhibitors, and use of hydrochloroquine and DAPA I'm using for many years. So IgA, I could control. The recurrence did not go to graft loss. Reasons for higher success rate than recurrent literature: extensive cardiovascular monitoring resulting in 26 revascularization before transplantation, no mortality due to acute coronary syndrome in the first year, and only 42 patients required revascularization post-operative during follow-up. Significant reduction in infection-linked mortality, which is common concern all over the world, especially in India. This is because absence of prednisone associated with less MMF, that is only 500 milligram. Look at my patients. Prednisone is 0. MMF is only 500 milligram twice a day, not 1 gram BD. 1 gram BD, I have given only to 2 patients the last 20 years whose weight is outing 104 kg or 105 kg. Otherwise, nobody gets 1 gram BD here. And same levels of, we are using the levels of tacrolimus since 2005. The overall immunosuppression is less, which reduces infection. Tacrolimus is less, because what happens is, in the absence of prednisolone, less MMF is required to maintain the MPA levels. You require less prednisolone. Leukopenia is very common in steroid-free transplants. If you take a count of 3,000, almost all patients will leukopenic. So I accept normal count up to 1,800 actually. I stop MF only when count is less than 1,800. No, 0 prednisolone, MMF 1 BD, and tacrolimus lower than most of the people use, and a normal steroid-based transplant is given at you give prednisone at a dose of 5 to 10 milligram per day, and in 2 years' time, the total cumulative dose exceeds 5 grams. And 5 grams is a critical dose in the infectious disease literature, which leads to higher rate of infection mortality. And patients suffer from cataract, hip fractures, typical steroid phase, recurrent infections, life-threatening infections, atherosclerosis, hypertension, diabetes, graft loss due to BK virus also more. So here, in comparison to literature, our graft loss due to BK virus is not high. Recurrent GN causing graft loss is only 1% of our series, which is 8.4% in the New England Journal series, which is 8.4%. But and good response to FSGS to recurrent protein FSGS to rituximab. Significant reduction in acute rejection episodes and antibody-mediated injections to the unit protocol, because I'm using rituximab also for glomerular disease at 2 milligram before transplantation, not to all, but most of the patients from glomerular disease, not to biopsy-proven and chronic interstitial nephritis. And I do not do any DSA monitoring. I don't think it works. It adds cost to the patient. I think biopsy, looking at the proteinuria, looking at the creatinine is enough to monitor this patient, because somebody gets DSA also. If creatinine is normal, biopsy is normal, I'm not going to do anything. I'm using flow cross-match for more than 10 years and single bead testing as soon as it was introduced in India for a long time. Then this has cut down the incidence of new onset acute antibody reaction post-operatively, which was frequent 10 or 12 or 30 years before. You do transplant, 1 or 2 patients don't pass urine, and biopsy shows significant antibody-mediated rejection. We don't see the picture of antibody-mediated rejection. I'm seeing 9%, but antibody-mediated requiring dialysis and ABO-compatible transplants is very, very uncommon. We should never say nothing happens, but it is uncommon. Protocol biopsies allow modification of treatment. For example, I will add everolimus for a patient with significant CI toxicity. I don't use everolimus because absence of tacrolimus is absence of kidney for me. So it's if somebody has CNI toxicity, does not mean you should stop CNI and replace everolimus. No, that will be a wrong approach. Cut down the dose of tacrolimus, add everolimus, and use both. Treatment of subclinical rejection, identification of BK virus identification, because I routinely screen for BK virus at least 2 times in the first 6 months, and 3 months protocol biopsy also tells me, and 1 year biopsy is there a picture of BK virus, because a monthly monitoring life for 1 or 2 years like Western countries is difficult. That's why 1 year biopsy will also guide me towards the BK virus identification. I think I have lost only 2 patients because of BK virus coming at 3 years. And addition of prednisone to progressive time serial biopsy, which helps me identify those patients who are challenging me. Okay, we are not fit for a steroid-free transplant program at prednisone. And believe me, many patients who are IFTA too, if you do the biopsy at 1 year and then you see the biopsy at 5 years, there will not be any IFTA. A uniform protocol throughout the series, because we did not divide the patient into multiple study groups, as has been done multiple others, like tacrolimus and everolimus or cyclosporin or everolimus, cyclosporin, aspirin. Our protocol appears to be superior to whatever you've seen. So advantage is no steroid side effect. Diabetes reduced 3.5 to 6.1% compared to historical cohort by own 43 to 25%. Leukopenia more common, so less FM required, because you cannot give 1 gram. If you give, count will come down to 500. So monthly cost of medical medications is much less. No graft loss due to recurrence of lupus nephritis. Anti-GVM anyway does not occur, but in membranous nephropathy. Glass after recurrent GFN is much less. FSGS is also less. Summary: patient survival 1 year 98 and 19 years is 90.6. I have entered the 20th year in July. Graft survival at 97.7, 84.1. Biopsy proven acute rejection is 86.7. Normal histology in 89% by 5 years. Fatal infections uncommon in prednisolone group, though I have tell you all mucormycosis, asperger, pneumococcal which I had, but most of the mucormycosis was curable because my approach is extremely quick and surgical. Mucormycosis first surgical disease, not a amphotericin disease. Steroid protocol continuing in 1,700 patients at 20 years now. In July 2005, it has 25 it has entered. 80% patients are without prednisolone. Anybody can see my files. Better cardiovascular profile shown because of absence of prednisolone, reduced PTDM, and better control of BP and limits. Thank you. No literature, only my data.
Thank you, Dr. Pathak sir, for sharing your real world data. It was huge, and we can see 80% of your patients are still on steroid-free protocol. We know you are a strong advocate of steroid-free treatment post-transplant, and your data speaks for itself. So in view of lack of time, so we'll start with initially the panel discussion. Moving to PP Verma sir. Sir, what is the, do you think, current evidence which supports steroid-free immunosuppression, and can we generalize it to Indian population, as we saw the data of Pathak sir, which is huge, voluminous, and still his patients around 80% are steroid-free or on steroid-free?
Thank you, Dr. Manish, for the invite and for the question. As you rightly put the question that can we generalize the data? My answer will be no. You cannot have total generalization that yes, you give steroid-free immunosuppression to all the patients. Vivek is a dear friend. He has got a large data. He is a fan of steroid-free immunosuppression for a very, very long time. Look at, you require two basic things. First of all the steroid-free protocols, none of the protocol has taken 100% patient on steroid-free immunosuppression. Number two, what Dr. Kinari was mentioning, even the Sailor study, there is a data on 7-year graft outcome. That's a long-term data is still lacking. You don't have 10-year, 15-year data on steroid-free immunosuppression. And more important, that will be clinical data. You require IFTA. You require biopsy data that how much fibrosis is setting up vis-a-vis patients who are on steroid and who are on non-steroid-free immunosuppression. So once you have got histological and clinical data, only then you can say that yes, possibly steroid-free immunosuppression can be more liberal. But certainly, there's no doubt that steroid-free immunosuppression has got a definite place. There's no doubt it prevents or it checks the metabolic abnormalities and cardiovascular morbidity. Few of the patients where I think the speaker initially also had mentioned, I will certainly choose to go for steroid-free immunosuppression. That is elderly, which are low-risk patients, prepubertal children, where I want the growth spurt is an important issue. Diabetics are pre-diabetics where I know that they are going to develop metabolic abnormalities. Patients who are non-ABO compatible transplant are patients who are non-sensitized patients, are patients who have got high risk of osteopenia or steroid toxicity. These will the select group. I will certainly like that they should go steroid-free immunosuppression. Now, which protocol as rightly mentioned, as Vivek is also practicing, and Dr. Kenari also very rightly mentioned, it is better to give for early, yeah, either steroid free or early withdrawal within 7 days. That is a better protocol. And I personally will vouch for that, that if you have to give steroid free immunosuppression, do not generalize, be choosy. Look at the patients who are going to get the maximum benefit till the time we have got long-term data published, till the time we have got long-term biopsy data of IFTA, what is fibrosis which is developing, till that time we have to be little choosy. And India, we have to be again more careful that we don't have that free liberty to have re-transplants. What Vivek also said, like I also have got just 2 or 3 patients who have received their third transplant. Other patients, there'll be many. I'll have more than 100 patients who have received double transplant. But even now, to get access to second or third transplant is with a minority. So every transplant is precious. So look for that you do not lose or develop rejection. We know that short time that rejection episodes, even if they are occurring little higher, but they may not be impacting the graft survival in the short or medium term. But once we have got enough data that long term also there is no difference in these patients who are steroid free or on steroid, that is the time we will be able to make a generalizable decision.
So I think, sir, in India and in transplant, we always manage rejection. We want to balance the rejection and infection. And
Correct.
we have the population is at more risk from infection. And Dr. Pathak sir has shown his data of long term also till a follow-up of to 20 years. And he has the data with lower immunosuppression usage like MMF also 1 BD, TAC also at minimal dose.
Vivek has
Uh,
been lucky in these results. What you are saying, they are, as he mentioned, they are better than the world literature results. Where at 20 years also, if he's having a 19-year graft survival of 60, 70%, he's fortunate. But logically, if you are going for a steroid-free immunosuppression, you have to be choose because he did not follow the protocols for following DSAs. He did biopsies in his patients, but whether DSA he is not following, he said he doesn't follow the DSA. The early signs possibly you will develop if the person is developing de novo DSAs. That is the time you will pick up because you more centers have to pool the data, and if more centers are having us, there's no doubt that in India infection is the dominant problem. We are not saying, I am not saying that steroid free immunosuppression should not be absorbed, should be resorted to. I am for it that we should have steroid free immunosuppression, but not generalizable, that we should restrict it to a limited group of people who deserve it. And once we have got enough data on long term, that possibly we will liberalize and increase the ambit.
So I think Pathak sir has started the data collection very well at his center, and the data is actually promising. And as sir is saying, we may not generalize this at the current moment, but with choosy patients, selected patients, we can try with the steroid avoidance or steroid free protocols. I will move on to Dr. Maitri. Dr. Maitri, do you foresee a shift towards routine steroid avoidance nowadays in low-risk patients, or still will it remain protocol specific, center specific?
Thank you, Dr. Manish sir, for the invite. And I'm really fortunate to listen to Dr. Vivek Pathak sir live. It was such an amazing and enlightening talk by him. Thank you so much, Dr. Vivek sir. steroid avoidance in low-risk kidney transplant recipients is definitely an attractive concept, particularly if we look at the long-term side effects of steroids use like metabolic, cardiovascular, and infection-related. But in India, of course, a blanket shift, just like what Dr. Verma sir said, blanket shift towards routine steroid avoidance may be unlikely in the near future because of various factors. First of all, if you look at our patient profile, many of our patients, many of our even the transplant centers, they may not be equipped with robust immunological workup. In smaller centers, it might be difficult. And these patients also belong to higher immunological risk classification as well. And if you look at the resources, again, as is a developing country with resource constraints, I work in a public sector hospital where we are looking at low socioeconomic status population. They hardly come for follow-up. After transplant, it is very difficult for them to keep up and come for follow-up. Frequent and reliable monitoring is important for rejection whenever we are looking at steroid avoidance protocols. And it is challenging outside of major transplant programs like Dr. Pathak sir's, where he has a robust follow-up infrastructure. And if you look at the economic considerations, again, episodes of acute rejection may be difficult to manage. I mean, not difficult, costly to manage, difficult from the patient point of view. And the margin of error is small in resource limited settings. Again, coming to the last point, that is about the current evidence. These randomized trials in low-risk populations suggest non-inferiority and real-world applicability in India, where infection burden is more, donor types are different, and HLA mismatch profiles are also different, needs to be studied in a, like as you rightly mentioned, in a multi-center kind of setup. So because of all of these factors, steroid avoidance may likely remain protocol specific and restricted to select high volume centers like SIRS with expertise and monitoring capacity and patient education systems which are in place to implement it safely. So over time, as the local data accumulates and follow-up systems also strengthen and more centers cautiously adopt steroid minimization or avoidance, and for well-selected low-risk patients, maybe it would be possible later on in the future.
Still, I think training plays a very important role in this because during our training, we have seen very few patients of steroid-free protocol or steroid avoidance. So that is a big thing which usually restricts us to accept a new thought, kind of, yes, is it possible in India or in a country, in a region? So, but I think our patients die more due to infection rather than rejection, and this is our problem, our nation's problem, and it has to be a solution. So, steroid is a free protocol avoidance. I think it's a good option in selected patients, though definitely to start with, and Dr. Patak sir can definitely guide us in this area. Now I'll move to my friend Dr. Jitu. Doctor, how do comorbidities like obesity, diabetes, infections, previous infections like tuberculosis influence your maintenance dosing decisions in the practice? How low you can go with the steroids?
Thank you so much, Dr. Manish, and thank you, Dr. Patrick, sir, for this excellent presentation. I think it's motivating, and I'm not sure how much my answer would be appropriate here after his presentation, because I'm a person who's been recently trained out, and I really don't have any experience with respect to the steroid-free protocol. But what I want to tell is that when you look at infections, obesity, and diabetes, the proportion of patients whom we are transplanting among the diabetes and obese are going up day by day. And it's the emotion of the resident or the practitioner to bring down the steroids at the earliest, as early as possible, as low as possible. But as Dr. Manish rightly said, it also depends upon the degree of training in centers like this, where they've tried for steroid-free protocols, how confident the practitioner becomes over a period of time. So I think I'm still not so confident. And so I tend to give an induction dose of 1 gram, and the very next day bring down to 20 milligram. And at the end of 14 days, bring it to 10. And at the end of almost 6 weeks to 8 weeks, I bring it down to 5 milligram. That is the protocol I follow for diabetes, obese. And with respect to the diabetes, that's the most important thing, because a very high steroid dose doesn't let you sleep. And overall tacrolimus also makes it a mess. And with respect to the infections, I become cautious in those patients who have already received induction doses, another immunosuppressants, or long-term steroids because of an underlying glomerulonephritis, because these are the patients I felt they get into major trouble even with low-dose steroids. And obesity and diabetes go together. So these, at the end of 6 weeks, I try to bring it down to 5 milligram. Further lowering, I'm really, really cautious about, because I don't have access to protocol biopsies many a times. So I don't bring it down to 5 milligram. I'm below 5 milligram. The only roadblock which I feel with respect to further reduction is, one is that many times I feel non-confident when it comes to the tacrolimus levels, because I'm not able to attain the target 10 to 12 or maybe 8 to 10 in ATG inducted doses, because we use a low dose ATG at 1.5 milligram per kilogram cumulative dose. And at that level, when I don't get a trough level which is adequate, I don't feel confident of bringing down the steroids. Second is that when you have an intermittent rejection, whether it's a biopsy proven or rapid rise in creatinine with no other reason, when in such conditions I don't feel confident. And third, when there is a slow graft function, when there is a fertile ground for a rejection, I still feel don't confident going below 5. So in spite of diabetes, obesity, and probably an underlying bacterial infection, I don't have the confidence of going below 5 milligram, and I try to maintain at 5 milligram. Maybe over a period of time, when I listen to great legends like Sir and other people, and when people get trained in areas where they do steroid-free protocol, many of us like me and others will become more confident. And over a period of time, we'll also resort to steroid-free protocols in selected patients, like Dr. P.P. Verma saying, and maybe we'll have better outcomes for these patients. Thank you so much for this opportunity.
So, as we are running short of time, I will take one final closing comment from Pathak sir. Sir.
If you ask me which are the most difficult patients for steroid withdrawal, it is a pediatric group.
Yeah.
It is a pediatric group.
So
Otherwise,
how much inductions do you use in pediatric
rejections
patients
are not
where you
high.
try for steroid?
Yeah, rejection doesn't happen, but they get more IFTA. They get more IFTA. So we have to add prednisolone down the line somewhere. And IFTA reverses. Since I am doing the protocol biopsies for almost everyone. So, but patients don't refuse biopsy to me. So that's why I could do nearly 7,000 biopsies, which has not been reported from anywhere in the world in a steroid-free protocol. Second thing I have answered, not only the patient, because nobody from India has reported long-term patient of graft survival. I have published my data at 12 years already. Now I'll publish at 20 years. Many people from, like Dr. Chapman, Jeremy, he came from Australia to see my files. Dr. Denon from Johns Hopkins has gone through my files of 2005. He was astonished. I said, you can look at the files, patients are doing well. He also went through my files for at least 3 hours in my room. I have no hesitation if any international group, peer reviewed group looking at my files. I have no problem because it's very clear-cut data. And rituximab used since 2007 for recurrent FSGS. I told you the reasons are what I like. I have got one patient last year from some transplant center country. Prednisolone, I will not say where. Prednisolone dose was 30 milligram at the 1 month, 20 milligram at the end of 4 months. She's got right eye cataract, monster face, hip fracture on the left side, cannot walk. And when the plus 1 gram of MMF, this is not transplantation. This is not right. This is not right. This is massive doses of what we have not done last 3 decades is we have got new induction agents, but how to manage the concomitant immunosuppression has not been done. The prednisolone doses, many centers have not come down with the use of stronger drugs. What was being done with dose of azoran cyclosporin days, with tacrolimus use, MMF use, say thymoglobulin use, prednisolone dose still remains 30 milligram at the end of 1 month. That is the problem. So I do not believe patients in India die of infection. I reject that outright because my patients are living at 20 years. Anybody can come from the country, can see files of 2005 in patients also. I can show. I have nothing to hide here. And some international giants have, many from India also have come. So patients are doing well. and I see intensive follow-up. I see the patient almost 40 times in the first 3 months. I don't allow them to go home for the first 3 months. They were with me. And that allows you to guide. That's why I don't do DSA, because what will I do DSA? Patient is protein free, his creatinine is 0.9. What will I do with DSA? That's why I don't do DSA monitoring. DSA monitoring is useful if the patients get into trouble. If the patient gets in trouble with, say, chronic antibody detection, then I look at the single bead test, that patient. But those patients whose prednisone free, 80% histology is normal, what will I do the DSA? Correct.
Even with steroids, we do get rejections. It is not like with steroids, we do not get rejections.
So
So
thymo
we do
induction
get
matters. See,
rejections.
if you see in India, most of the people are not having the guts to go in thymo beyond 1.5 or 2. The maximum dose of thymo I have given to one child is 15 milligram. CD3 is hatdharmi in Hindi. Sometimes whatever dose of thymo you give doesn't go down. Lymphocyte monitoring doesn't matter. What matters is CD3 monitoring, and
So
that will guide
you
you.
monitor CD3 prior to giving the dose of ATG, sir.
No,
Increasing
that
the
doesn't
dose.
matter. I want to see what happens after the first 2 doses, and then I give the third dose by food. I don't give 3 doses consecutively. And it's very important that first dose you give intraoperatively when surgery is going on at that time, because it prevents the reperfusion injury. So second, I look at the CD3 sent on third day, and then I decide the third dose. That's why my dose varies from 3.9 to 4 milligram. On average, I'm not going beyond 4.2 or 4.3 to 8.5. Highest which I have ever given for one patient is 15. That patient is living even today, 7 years or over. But 8.5 for few patients, because CD3 will not come down. Such patient nowadays, I don't go for CD3, but then I simply add 5 milligram of prednisolone, because cost goes up if you go on giving indefinitely the higher dose of thymoglobulin. But thymoglobulin will exactly tell you, like potassium before dialysis and after dialysis, how much thymoglobulin to give. No other test will give you. So here I can cut down the dose or increase the dose. And along with it is very important, we don't use the patient's 1 gram of MMFBD. That is fatal. That's why people die of infection. 20
So
milligram prednisone at the end of 1 month.
you have huge data, a lot of experience. Single webinar, I think a small webinar will not be enough. So we will definitely come back to you, sir, some other
I
day.
can answer all
So,
questions on this. No problem. I have practiced steroid-free AB incompatible also, but today I'm not talking about that. And I'm restarting in steroid-free AB incompatible as well.
So it's already about to be 8, so we are running late. So I would like to thank each and everyone, including our speakers, panelists, for taking time out, and your expertise has taught at least me new things, a newer horizon. Maybe in future I would like to step in. So thank you everyone. Thank you all participants for joining.
Thank you for organizing this.
Thank you, sir.
First of all,